Welcome to this pediatric nursing video on malnutrition presented by Mr. Nagesh Sir. We will cover the complete theory, practice questions, and golden points for quick revision. What is malnutrition? It is a pathological state caused by a deficiency or excess of essential nutrients. Protein energy malnutrition, or PEM, commonly affects infants and young children, most often between 6 months and 3 years. The etiology of malnutrition involves the cycle of malnutrition. Infection leads to decreased intake, which causes malnutrition, lowering immunity, and leading to more infection. Malnutrition can be classified using several systems. Gomez and IAP classifications use weight for age, while Waterlow uses height for age and weight for height. WHO classification uses Z-scores and is the current standard. The Gomez classification measures malnutrition based on weight for age percentage of the Harvard reference median. However, its drawback is that it doesn't distinguish between acute and chronic malnutrition. The IAP classification, or Indian Academy of Pediatrics, also uses weight for age percentage. Normal is defined as 80% or above. Waterlow classification is important because it distinguishes between chronic malnutrition, known as stunting, which is measured by height for age, and acute malnutrition, or wasting, measured by weight for height. The WHO classification is the current standard, based on Z-scores or standard deviation from the median. Severe acute malnutrition is defined as a weight for height below -3 SD, MUAC below 11.5 centimeters, or the presence of bilateral pitting edema. The main clinical types of PEM are kwashiorkor, resulting primarily from protein deficiency and marked by edema, and marasmus, caused by a lack of calories and protein characterized by severe wasting. Marasmus typically affects infants and is caused by severe calorie deprivation. Key signs include an old man or monkey face, baggy pants due to loose skin folds, and severe muscle wasting, but no edema. Kwashiorkor usually affects toddlers and is due to low protein intake. Signs include moon face, pitting edema, flag sign, flaky paint dermatosis, and often a potbelly due to a fatty liver. This chart summarizes the key differences between marasmus and kwashiorkor, including age, primary deficiency, and clinical signs like edema and wasting. Assessment of malnutrition involves anthropometric measurements like weight and height. Mid-upper arm circumference, or MUAC, is best for community screening, measured between the acromion and olecranon. The MUAC measurement uses Shakir's tape. For children aged 6 months to 5 years, a circumference below 11.5 centimeters is considered severe acute malnutrition, or the red zone. Diagnostic criteria for severe acute malnutrition in children aged 6 to 59 months require any one of 3 conditions: weight for height below -3 SD, MUAC below 11.5 centimeters, or bilateral pitting edema. Management of severe acute malnutrition follows WHO guidelines, divided into 3 phases: stabilization, rehabilitation, and follow-up. The 10 steps of management must be followed sequentially. The WHO 10 steps are divided between the stabilization phase and the rehabilitation phase. Stabilization focuses on life-saving actions, while rehabilitation focuses on catch-up growth and follow-up preparation. Step 1 addresses hypoglycemia, a silent killer in malnutrition, defined as blood glucose below 54 milligrams per deciliter. Prevention involves feeding every 2 hours, day and night. Step 2 focuses on preventing and treating hypothermia, defined as an axillary temperature below 35 degrees Celsius. Kangaroo mother care is the best management method. Avoid hot water bottles due to burn risks. Step 3 addresses dehydration. Standard ORS is contraindicated due to the risk of heart failure. The fluid of choice is Risomal, which contains less sodium and more potassium than standard ORS. Step 4 is correcting electrolyte imbalance. Malnourished children typically have high total body sodium, but low total body potassium and magnesium. Treatment involves supplementation and sodium restriction. Step 5 is treating infection. Always assume infection is present in SAM, as typical signs may be absent. Administer broad-spectrum antibiotics to all admitted children. Step 6 is correcting micronutrient deficiencies. Give a large dose of vitamin A and daily folic acid and zinc. Crucially, do not give iron during the stabilization phase. Step 7 involves cautious feeding using the starter formula F75, providing 75 kilocalories per 100 milliliters. The goal is maintenance, not immediate weight gain, to prevent organ overload. Step 8 is achieving catch-up growth using the formula F100, which has 100 kilocalories per 100 milliliters and higher protein. Start iron supplementation now. The goal is rapid weight gain. Complications of malnutrition include metabolic issues like hypoglycemia and hypothermia, infections like sepsis, organ failure, and deficiencies like anemia and blindness. Let's review key one-liners. Protein deficiency leads to kwashiorkor, while calorie and protein deficiency leads to marasmus. Stunting, or height for age, is the best indicator for chronic malnutrition. Further review. Flag sign is seen in kwashiorkor. The monkey face is a sign of marasmus. The formula for the stabilization phase is F75. Standard ORS is contraindicated in severe acute malnutrition. Practice question 1. The best indicator of long-term nutritional status is height for age, which measures stunting. Weight for height measures acute malnutrition or wasting. Practice question 2. Flaky paint dermatosis, where the skin peels like old paint, is a characteristic feature of kwashiorkor. Practice question 3. For a conscious child with SAM and hypoglycemia, the immediate management is giving 10% glucose, 50 milliliters, orally or via NG tube. Practice question 4. According to the IAP classification, grade 4 malnutrition is defined when the weight for age is less than 50%. Practice question 5. The baggy pants appearance is a classic sign seen in children suffering from marasmus due to the severe loss of muscle and fat. Practice question 6. Hyperkalemia, or high potassium, is not typically seen in severe malnutrition. Instead, children usually suffer from total body potassium depletion, or hypokalemia. Practice question 7. Mid-upper arm circumference indicating severe acute malnutrition, the red zone, is less than 11.5 centimeters. Practice question 8. Iron supplementation is delayed initially because free iron promotes bacterial growth and sepsis in the acute phase of SAM. It is started during the rehabilitation phase. In summary, remember the key differences between kwashiorkor and marasmus, the definition criteria for SAM, the 10 steps of management, and avoid standard ORS and initial iron supplementation.